Okay, so a quick lecture on stroke. So stroke, there is two things we need to know. We need to know what the definition between a stroke and a TIA. So remember, stroke can be ischemic or hemorrhagic. That's why we need to do a CT head, very, very important, before we give the patient an aspirin or anything like that, because if it's ischemic, if it's hemorrhagic, it's a contraindication. Bleeding, you can't give aspirin, can't thrombolyze. So very, very important. Management is totally different if it's ischemic or hemorrhagic. Hence CT head is very, very important. TIA. Now TIA, this is, you can explain it as a sudden onset of a neurological symptoms that's less than 24 hours, is brought by a transient decrease in blood flow, so less than 24 hours. So in terms of management, very important. So patient comes with this with who had a signs and symptoms of a focal neurological symptom that has already gone away, okay, is finished, but less than 24 hours, patient is well now. Then management, what do we do? So we are suspecting patient has TIA. Now we need to give the patient aspirin, 300 milligrams immediately. Okay. Obviously you need to make sure there is no contraindication or any other concerning things, and you need to refer the patient to a specialist. Now what do we do, how and when? So if the patient generally, if the patient has a suspected TIA and it happened within the last week, very important, within the last week, then you give them obviously aspirin 300, and you need to do urgent assessment within 24 hours, very important. Sometimes you have a patient who are already taking aspirin, low dose, 75 milligrams. You're thinking, oh no, what do we do? Continue with the current dose, and obviously, and you until being reviewed by the specialist, the stroke team or the stroke consultant. Now, if a patient is had a stroke and it's been more than a week, okay, it's been more than a week, focusing here, more than a week, then you patient will take the 300 milligrams of aspirin, and you need to refer them to a specialist assessment within 7 days. They need to be seen. Okay, this in the middle here, this patient, basically a bit concerning patient, we need to think about admission here, or at least observation, urgent observation. So those who have crescendo TIA, meaning who had more than one suspected TIA, and a few other things as you can read here, suspected of a cardioembolic source or severe carotid stenosis, or any other patient who may be unable to attend the urgent review, or who lacks a reliable observer at home to contact the emergency services if the patient has another symptoms of this occurring again, like a TIA symptoms or stroke symptoms again. So just to let's say recap of TIA again. I know it's become overwhelming, so you need to focus on what is TIA. Symptom goes away. Remember, guys, treatment very planned. We all know that it's 300 milligrams, but we need to know about when to refer. It depends. Okay. Now moving on to stroke, we all know what stroke is. We need to do a non-contrast CT head. Now management for ischemic stroke, so 300 milligrams aspirin for 2 weeks, very, very important. Okay, after 2 weeks, then you go to 75 milligrams clopidogrel generally. Okay, problems arises when the patient is basically, they can't tolerate clopi. What do you do? And so on. As you can see, this bullet point here and here, if you read it, is the other problems. So we have said again, let's recap again, aspirin 300 for 2 weeks, follow after that 75 milligrams of clopidogrel. If a patient has AF, which caused, so obviously we know that AF can cause clot, and that can lead to ischemic stroke. So therefore we patient sort of continues, has this medication 300 milligrams for 2 weeks, and then we put them on anticoagulation such as warfarin, such as DOAC, for anticoagulation for their AF. We don't give them clopidogrel like here. We basically give them anticoagulation. thrombolysis for acute stroke. So obviously, if the patient comes within 4.45 hours, then they can be we can thrombolize them. Okay, we can thrombolize them. So it's very, very important. We do understand this one. Antiplase can be used here. Thrombectomy is also important as well. Please read about thrombectomy. If they come in, I think, don't quote me, I think it's within 6 hours of the onset, then we can still the I think the nice guideline says that if the patient comes within 6 hours, is thrombolysis plus thrombectomy. Even if it's more than 6 hours, we can do thrombectomy. Please read about thrombectomy. Don't quote me here. Okay, so obviously this is important here. We need to know whenever we're asking for carotid stenosis. Okay, obviously that can cause ischemic stroke. Very important investigation is going to be duplex ultrasound. Duplex ultrasound. Generally, there's few sort of criteria when to do the endarterectomy. Generally, just learn this one, more than 70%. Some other guidelines says less than that, but for the exam purposes, more than 70% is enough to go by. Okay, and the sort of feeding tubes for stroke. Now, generally, patients who have stroke, they have risk of aspiration. So obviously, the swallowing is not safe, so it can lead to aspiration, which can lead to aspiration pneumonia. So therefore, we review the patient by salting, speech and language therapy. They will assess the swallowing ability. Patient who are unsafe for swallowing will be placed on NG tube temporarily, NG tube, and obviously we can't keep NG tube for long. It's temporary. Okay, so therefore we need to think of more long-term feeding, such as a PEG or such as a rig tube, which is the same thing as PEG.